welcome to our first Grounds for Discovery. So Grounds for Discovery is our first networking event as a centre. We launched formally as a centre last January, so we're nearly a year in place. We've spent that year very busy, but largely focused on getting the building blocks right. So this feels like a big moment for me, that we're at that point where we can actually bring people together. The benefit of in-person networking is astounding for research and for practice. I'm always reminded of a story that I first heard when I was in Cambridge, and it is known as the Great Coffee Breakthrough. So I'm going to share the story with you to demonstrate the importance of the in-person networking. So there were two different postdoctoral researchers working in Cambridge, both on either side of the same problem. Neither of them were making much progress, and they were at an event like this where they happened to sit beside each other and realized that they were working on either side of the same problem. Together, they went on to win the Nobel Prize, not so many years after that. They used their prize money to set up a new building in diabetes research, where on the ground floor you had the basic sciences, the lab-based sciences, the wet sciences. The floor above that you had the epidemiological sciences, and on the top floor you had a coffee room for everybody in the building. So you had all the different dimensions, all the practitioners, the doctors and nurses in diabetes care, the community workers, and all the scientists all in the same coffee room together. And it made for wonderful, wonderful science and research outputs. So that's where the benefit of the in-person networking was demonstrated to me. So hopefully we can bring that to our centre. I just want to say a very quick thank you to Denia. So whenever we conceive a notion, a plan, wouldn't it be nice to have X, Y, Z? It's Denia that actually makes it happen. So we wouldn't be here today without her. So thank you very much, Denia. Before I introduce our guest speaker, I just have two small announcements. The first is our summer conference. Summer conference save the dates will be out formally next week, but as a heads up, they are the 4th and 5th of June, and it's going to be hosted here in UL and on campus. We announced the student prize, the implementation student prize, which is named for one of our founders, Alice Coffey, who retired earlier this year. The details of that are up on the website. The deadline for the students' entries is the end of April, and the presentation of that prize will be at the summer conference. And Alice confirmed yesterday, actually, that she will come back to present that prize directly. So, without further ado, I want to introduce and thank Professor Geoff Curran, who has come from Arkansas.
Hi, Arkansas it is.
And he'll actually do his own detailed introduction. So I will hand over to Geoff, and thank you very much.
Okay. Thank you for having me. Okay, yeah, so I get to wreck your morning after talking and sharing and coffee and whatever to hit you with, research designs that are complicated. So I will only torture you for about 30 minutes. So hopefully it won't be too bad. I'm very happy to have this role here, and I've had it since about 2022. So it's great to be back, and I love to be here with you. Okay, so I'm going to be talking about these hybrid study designs. So let's go. So here are the goals, sort of the basic structure. So I'll share the basic notion. We have three types of hybrid studies, and I'm going to try to give folks a sense of why you might think about using them and when it might be a good time and when not. And also to share a few thoughts about how to get started, and then hopefully have time to take your questions. I also like to share too. I have a stutter, and I get pretty nervous up here when I give talks. I've been doing this for a very long time, and I still can't shake So I'm going to have a little water. Take a deep breath, and I'll calm down in a few minutes, I'm pretty sure. Okay. So thank you. Okay, who is this talk for? This is my guess. Folks who are hybrid curious. Folks maybe have heard of this idea, haven't really tried one yet. You might be thinking about it. It's also focused on people that might be doing intervention research, out there working on interventions, trying to test their effectiveness, but you might be thinking, hey, maybe I should be learning more, caring more about the implementability of that intervention, and how we might need to support uptake of it in the real world. And I'm hopefully going to offer some notions on how to start to do that while you're developing and testing those interventions. And also, there could be some people here who are already in the field and already doing this stuff, and they might need a refresher. So this might be you now, like, I'm not so sure, and by the end, in 29 minutes, that's what I hope that you all will be feeling. Okay, I am a sociologist by training, so I have been doing this kind of work even before it had the title of implementation science. I started doing this work in our U.S. Department of Veterans Affairs, which is the only national publicly funded healthcare system in my country. And they had this cool notion in about 1998 to say, hey, we want to fund some centers who will focus on how best to implement our clinical practice guidelines, which are not currently being deployed very well. So it was practical, but also science at the same time. And hence, in this context, these kind of hybrid study notions were born. I've been doing a lot of studies for a long time. I mostly do what you will see as sort of hybrid type 3 studies, where we're developing and testing in implementation trials competing implementation strategies, how best to implement practices. And in my work, I've also done a lot on these designs and methods, and that's why I'm here today. So I like to focus on, or let people know that I have been doing most of my work for my entire career in the clinical setting, healthcare interventions, healthcare contexts, okay? And for about the last 10 or 12 years, I've been doing a lot of work in pharmacies and with pharmacy practices, which has been fascinating. Now, I know that a lot of folks now, and in CIRcUL especially, you're trying to expand out of just healthcare and kind of apply these concepts and frameworks to non-health interventions and non-health settings, and that's fine because it all works there too. But I started my work here, and a lot of the field kind of, started here and is frankly still here. Okay, so I think a lot of you already have a sense of what implementation science is, but I often like to start with this very simple language that I started to use a while back and then published on it. And for hybrid studies, this actually is quite helpful. So I will be using a term called the thing. And what I mean here is the intervention, the practice, the program, the innovation that is the subject of implementation, concern, or support. And so a whole lot of you might be actually doing more of clinical intervention research where you're out there trying to study how well things work. When patients get the thing, Do they get better? You might be doing trials where you compare thing A versus thing B to see which one works best. Great. Implementation research, then, in very simple languages, we are trying to find out how best to help people and places to do the thing. That's our job, okay? We have a fancy term, it's not that fancy, implementation strategies. In real simple terms, this is the stuff we do to try to help people and places to do the thing, and a lot of us in our field focus on those, developing and testing strategies. So in our work, the main outcomes have to do with the performance of those strategies, okay? How well do the strategies work to help people to do the thing? And so our primary outcomes, when you get right down to it, are how well and how much did the people and places do the thing after we tried our strategies. That's our field. So in hybrid studies are varying ways that we explore the effectiveness of something and ways to do the thing in the same study. That's the critical part. Not a separate study. Not we find out it works, we do 3 trials over 900 years to show that it works, and then you hand it off to folks like me who's never seen it before, and then we try to figure out how to get people to actually use it. Maybe that's dumb and takes too long. I think so. I'm biased. So these are actually notions about how to do studies where you combine this stuff so we can maybe go faster. Okay? Here's our first hybrid design paper from 2012. Wow. So why this hybrid study notion? Can we hurry up, please? The whole point of implementation science is to try to more rapidly translate what we know works to most everybody gets it who should be getting it, right? So hybrid studies, we blend research questions about the thing and how to do the thing in the same study, hopefully to save time. Maybe we don't have to wait for that perfect effectiveness data before we move into trying to answer implementation-y questions. Maybe, for lack of a better word, we can backfill effectiveness data that is still needed while we are explicitly focusing on testing implementation strategies to help people to do the thing. And by the way, we might want to know how the intervention outcomes relate to how well the strategies work. I would assume, but if we don't look, we can't prove it, but I assume that the effectiveness of things varies by how well they are implemented. And if you have data from both sides in these kinds of studies, you can actually show that. Okay? Now, I do want to say, people were doing these kinds of blends before I and my team kind of did some thinking and tried to come up with some types. We didn't come up with the idea. It's been going on for a long, long time. We just tried to bring some structure to it, some options to go about it, and that's where we are. And we're still trying to do that now with more and more papers and more guidance. Okay, so we proposed in our first paper, and we still support this notion of 3 hybrid types, okay? So hybrid type 1 is largely focused still on testing the intervention. It's focused on the thing. Does the thing work? But we're going to take a little bit of time and money and staff, and we're going to gather information on its implementation, its implementability, on how it went during the study to implement it and try to learn from that experience to help us to possibly go faster to figure out how to do this in the real world. Okay? These studies are frequently person-level, randomized trial, sort of in the classic sense. It's still an RCT of something, but we add an implementation-focused process evaluation using an implementation science determinant framework to guide us on how to look at the implementability of the thing. What are these determinants, as we call them in our field, but barriers, enablers to doing the thing in the context of the trial, and to try to figure out and to possibly forecast what potential real-world strategies might be needed once we show that this thing works still. What might we need to do implementation-wise to support it actually happening? Okay. Hybrid type 3 is basically the opposite. It's focused on testing implementation strategies, okay? But we're still evaluating the performance of the thing. How is the thing working while we are studying how best to support its rollout? These studies are frequently cluster randomized trials. Not always, but they are frequently. And the primary outcomes are implementation focused. Things like adoption. What was the level of adoption of the thing in the places? Reach. Did it reach all the patients, all the people that we wanted to get the thing? Fidelity. When it was delivered, how well was it delivered? There are lots of different kinds of designs in this area. Study designs, a stepped wedge design, smart trials, there's rollout designs now. Some cool things happening in our field on how to study this kind of thing, hopefully in a more practical way. But, okay, intervention outcomes are secondary. Okay? It's frequent now to have these kinds of studies study the cost of implementation strategies to try to get a sense of the cost effectiveness of implementation strategies. And there's a push now to study mechanisms of action of the strategies that we're trying to test. Why do they work? Okay? Using testing theory about why those might work. And then the messy hybrid, where you're kind of trying to do both of these things more or less at the same time. You're trying to understand how well a thing works, and you're also simultaneously deploying some hypothesized to be real-world feasible implementation strategies in the same study. Now, there's a number of ways that you can do this, but in these studies, you have oftentimes co-primary outcomes, or maybe one or the other, but you're studying the effectiveness of the thing, the health outcomes, but you're also studying these adoption, reach, fidelity type outcomes. There's lots of different study designs that you can do with these hybrid twos. The more complicated ones are kind of dual randomized, where within site you might randomize patients to intervention A and B. At the site level or provider level, you might do more of a cluster randomized study of competing things. Now, there's not a lot of those. They are out there. They do happen. It's a high wire act. There's a lot of risk, but they can be very cool. The most common type 2 that folks use are what I kind of call the pilot version for the implementation strategies, where it's still a patient-centered randomized trial of something, but you have already developed some real-world implementation strategies that you think are going to perform well, and you sort of do a one-arm study of those. So it's like a two-arm for the thing, but a one-arm kind of pilot study of the strategies in service of the trial. Now there's a little danger there, which I will share in a minute. And then there's this other version, which happens a whole lot, which is essentially a single-arm trial on both sides. You have an intervention that healthcare systems are devoted to, and this is what we're going to do. It's matched to an implementation strategy with no interest really to compare that either. And they're married, and it's sort of like a program eval approach where we're going to do them both at the same time, probably a pre-post, possibly a post-only, and look at both of those outcomes. It's still a hybrid 2, but it's not a trial design. Okay? Okay, so when to consider doing a hybrid 1? It's normally in the case when effectiveness data for the thing is limited. You might be adapting something that's been shown to work in other places, but you're trying it in a new place or with a new population. So it's probably too early to focus on implementation strategies. But under these kinds of studies, you can really learn a lot about implementation issues, its implementability, even in the more ideal conditions of the trial, and it's a great place to kind of start and to kind of cheat forward, right? It's still mostly about does the thing work, but we're trying to cheat forward and learn something about how to roll this out, okay? Remember, all intervention studies, all clinical trials use implementation strategies to support the delivery of these interventions. We just normally don't call them that. And we normally don't measure implementation outcomes per se. And in those kinds of studies, and rightly so, we know that some of those strategies are not feasible in the real world. They're not going to be used to support the widespread adoption. We might be paying clinics to take part, paying for the intervention, paying for the care, paying for people to show up, doing intensive training of folks. The whole point here is to ensure that the thing is delivered well, because that's what we're trying to study. But even under those conditions, which are somewhat artificial, there's a lot that can be learned from studying how well that those strategies work and trying to talk with people about, hey, what kinds of strategies do we think might actually be needed when it's time to do this for real? If any of these might work, great, but how might we need to come up with some new ones which might actually be feasible in the real world, okay? Hybrid type 3, when might we want to use those? We sometimes proceed with implementation studies without completing a full course of effectiveness studies. Now, this happens all the time for many and varying reasons. There are practices out there that have kind of okay evidence, but a healthcare system has made up its mind, we're going to roll this stuff out. And so a hybrid 3 can be super helpful. We can help that system learn how to best do the thing, but we're going to measure outcomes of the thing. And this kind of thing happens all the time, okay? You also might be making a relatively minor adaptation to the thing, maybe not enough to have a funder go, you need to do a whole new trial, but we're going to do a minor sort of tweak. We're going to focus on its uptake, but just in case, we're going to measure how the thing works too, okay? And for folks like me who are sort of steeply in this field, we might want to know and have data, like I said, on how clinical effectiveness might actually vary by the level or quality of implementation. A policymaker might really have an interest in how much fidelity do we actually need to get enough of the healthcare outcomes that we want. We always assume that, when we roll this out, it has to be done exactly how it was done in the trials. You got to follow it 105%, or else it's just not going to work. And frequently, that's not true. But we're only going to be able to understand those things if we study these at the same time. Doing these kinds of studies, these are often cluster randomized trials, and so you need a bunch of places in order to do this kind of work, or it's very helpful, and sometimes that is not easy to do. Okay, there's a lot of study designs and more happening, especially for these kinds of studies. You have to partner with folks, and they have to be on board with what you want to do. And I can tell you that these days, a lot of healthcare systems, clinics, pharmacies, whatever it might be, they don't want to do a parallel cluster randomized trial where half of the sites get the comparison strategy and half gets the one that we explicitly hypothesize is better. They don't want to do it. So most of our studies are stepped wedge designs where it's a crossover design where everybody starts with strategy A, and then everybody moves over to B. So everybody gets both, and we study the difference that way. And there's other kinds of designs too. For hybrid type 3s, you got to remember, you have to talk about the evidence of the strategies that you are testing. Some might be novel, but a number of these strategies might have some evidence base, either from the same context or from a similar intervention. But you have to talk about that too. And very critically, you're going to try to measure these intervention outcomes or clinical outcomes. These kinds of studies are a lot easier when those health outcome measures are readily available. If you're doing stuff in diabetes, in hypertension, those values are more normally going to be taken on a frequent basis as healthcare happens, and you probably have easier access to those. In some other parts of healthcare, in mental health or other areas, those kinds of routine measurement of symptoms and functioning are not happening. If you have to go out and collect those data yourself, that's going to cost more time and money, and it makes this stuff harder. Okay, so when might you consider a hybrid 2? So, intervention effectiveness data are likely available on this kind of thing, this kind of intervention, but perhaps not for the context where you want to test it, or the population that you want to try it in, or both for your study. You might already have data on barriers, facilitators to doing the thing. You might already have some idea of some potential real-world strategies that you might want to test, because a lot of times folks have been out there trying to do some of this stuff for a while, and some of the stuff is known. Or maybe you've done some of this work on its own to try to be ready to test some strategies at the same time. Or you might have a situation where you want to study or roll out in a program eval some intervention with a bit of a baked-in implementation approach, which you're not going to separate, you're not going to compare either. We want to roll this out now. We don't want to compare, either intervention. Funders are ready to go. We want to roll this out. Almost by definition, that is a hybrid type 2. And that happens a lot in science and in just public practice. By definition, it's a hybrid 2 study. And those happen all the time. Okay. So, with this hybrid type 2 idea, it is a bit of a high-flying act. It is important to have an explicitly described implementation strategy or strategies that is thought to be plausible in the real world. This is a clear distinction from a type 1. You have to explicitly measure those implementation outcomes because you are evaluating the performance of those strategies, and in hybrid type 1, you frequently don't. In a type 2, I mean, it's helpful at any point, but especially in a type 2, it's really critical to be clear about what the components of the thing are and what the components are of the implementation strategy. Sometimes that's not so easy to understand, and sometimes you have to make choices and say, for our study, this is what I think. For example, delivery format. Giving some intervention live in a group setting or over an app, is that a component of the thing, or is that an implementation strategy? There are implications for your study however you decide. And I'll also add this too. It really helps to build in some time in your timeline for the implementation strategies to likely maybe get a little tweak. The big danger with a hybrid type 2 is you do all this work about enablers and barriers, you choose strategies, a number of them evidence-based, you launch the study using those strategies in service of your trial, and the strategies stink. Or they don't work as well as they need to allow for the implementation, the intervention study, which you're trying to do, use them in service of. So sometimes, frankly, it hasn't happened a whole lot that I've seen, but it has. And then you kind of have to go, oh, fidelity to the thing is not so great how we're doing it. So we're going to have to stop for a second and try to make that better and then relaunch. So this is why some folks and some funders in my country get a little queasy at the type 2. Hybrid 1s and hybrid 3s are going over pretty good. And hybrid 2s, yes and no. It just kind of depends. Okay? How am I doing on time?
You have 7 minutes.
7 minutes? No problem. Well, a little. In 2022, I need my glasses to see the slide. In 2022, we did a paper on okay, people have been trying to, use these things for 10 years, and here's how we messed up, and here's how we're trying, here's stuff that we missed, and I'm not going to cover a whole lot of those because I don't have time. But I am going to cover sort of a little tool that we made, which folks do seem to find helpful. Lots of folks seem to sort of hear about this hybrid notion, and they go, hey, I want to do both too. But which one might be best for me in my situation right now? So we came up with 4 easy questions to try to help you to hone in on what might make the most sense. Okay, and these are in the paper. You can go grab it, but I'm going to cover these really quickly. Question number 1, or variable that you have to understand and care about first. What is the nature of the effectiveness data of your intervention, of the thing? Okay? How strong is the evidence? If it's very to moderately strong, and if you already have a notion that you're not going to need to adapt it very, very much for a new place or population, you might be in a pretty good place to consider a type 3 or a type 2, depending on how much you think it might need to be adapted. If you have no results or mixed results, or you have results that are not exactly in the population or context where you want to test it, you might still be in a hybrid 1 scenario, or possibly a 2. Next, question number 2. How much do you expect the intervention will need to be adapted for where you want to use it? A little? Consider a type 2 or 3, moving more into how to help people to do the thing. And have this adaptation process, which you have to do via co-design with people who are the end users. You can kind of build that into the study and kind of move faster there. If you think you have to adapt it a lot, if you have a notion like, in order to adapt this for population X or context Q, we might have to mess with some of like the known mechanisms of action of the thing. Well, depending upon the comfort level of you and your team and the funder, you might be solidly in a type 1 situation, or possibly in a type 2 if it's not a whole lot and you already have some sense of what that context might need. Question number 3. How much do you already know about implementation determinants for the intervention in your context? And by that I mean barriers, enablers to doing the thing in the context and or population where you want to go study it. If you don't know much yet. And you also need to focus on effectiveness data of the thing pretty squarely in a type 1 situation. If the effectiveness data are strong and you know enough already about the place to develop strategies or a package, you could very well be in a type 2 or possibly even in a type 3 situation. Number 4, and finally, how ready are you to evaluate real-world implementation strategies or packages thereof? If you're not ready at all, maybe a type 1 is indicated, especially when you still need those data as a primary focus. You might be ready, but you have to focus also and maybe equally on how well this newly adapted thing works. Could be very, very well in the type 2 area. Or you are ready, you have strategies, you match them to determinants. Maybe you've even done some pilot testing. And the effectiveness data are strong for the thing. You could be in a type 3 situation. Now, I understand that even with these 4 questions, there's a lot of ifs and thens. And you have to make a lot of calls. I'm like, how much am I adapting? How good is this evidence? How much do I actually know about the place? And what can be challenging when you're trying to write these grants is you have to make these arguments in a convincing way to the funders who don't know you and love you, and they could be cranky, and they might not buy this. So you have to work on this hard, and this is a team sport, okay? Don't write this stuff by yourself, okay? Have to work with a whole lot of folks. So I'm going to do 2 more slides, and then I'm done. Remember, don't need to do a hypo study. There are lots of times when it just might be too early. You're in efficacy land. You don't know it's safe yet. It might just be too early. There are times on the other end when you don't need to look at intervention effectiveness because we don't need to show that it works. I do stuff around implementing vaccines in pharmacies and other places. We're not going to test the effectiveness of the vaccine. It's been done already. We don't need to. So we're only going to focus on those strategies and those outcomes. However, I think that it makes sense when you think about this stuff to try to explicitly justify why you're doing a hybrid in the first place, why I want to do this kind of combo, and which type it might sound or lean mostly like. A lot of studies, as I said earlier, are hybrids without being named as such. Some of them, folks name them as hybrids, but they don't say it's a type 1, 2, or 3 because they feel like, this is kind of like a 1.67. This is a hybrid 2.41. And they don't want to say that because it's awkward. And the funder might not necessarily know a whole lot about these. And so there are times, and you might think it's weird for sort of the mayor of Hybridville to say to people, no, you shouldn't name the type because I know where this is going and they aren't going to get it, or it's going to cause you more problems than if maybe you just talk about your questions and what you're trying to answer, and you talk about the science. It's hybrid all day long, but you might not have to signpost it. For other places, they want to see that. Maybe not so much here in this country yet. In my country, our big funders, they're expecting this stuff and they want to know, and sometimes that's good and sometimes that isn't. But that's just how it is. Take-home messages. I think this is my last slide, or close to it. Okay. If you're used to doing intervention, development, and testing, hey, consider a hybrid type 1. Explore the implementability of the thing now. Why wait? Okay? If you're adapting some intervention for a new context, for a new population, or you are combining a set of evidence-based practices that on their own have a good evidence base, but in your package, they've never been tested like this, normally. Hybrid type 1 makes a lot of sense because, hey, in this package, it's never been tested like this. But we already know that a lot of this stuff works, so let's study implementability now. We don't have to wait, okay? So, when you're thinking about this hybrid stuff, seek assistance from IS experts at CIRcUL. They're right here. I'm right here. I'm a faculty member in your institution. I'm right here. I also just like to say, too, there's a lot of published protocol papers from funded studies like these. There are hundreds and hundreds, and those are super helpful because you see how people use language that they got away with because it's a protocol paper, so they got funded. And you can try to see how people frame this stuff, maybe in your, in diabetes, in the ER, in ICU, in primary care, and that stuff can be helpful. Last slide. In the past 5 years, there's been a lot of papers on these hybrid designs trying to sort of expand the idea. Our first paper and a few afterwards were like trial designs. It's not all about trials. So there's a hybrid paper that is focused on like observational studies using this hybrid notion. A lot of people do this kind of work in policy implementation, and there's a paper that I helped to ting a little bit on about hybrid ideas for policy implementation research. Somebody did a pretty statsy, mathy paper, really trying to hone in on these weirdos in the middle, these sort of dual randomized hybrid type 2s, which most folks are scared of, which I totally get. A colleague of mine and I wrote a paper a year and a half ago about similarities and differences between pragmatic trials, which you've probably heard of, and hybrids, mostly types 1 and 2. My name is on this, but I edited like the first 2 paragraphs and then I was done. I call this the hybrid type 2 math paper, and I don't do math, or as you folks say here, maths. So a bunch of math people kind of went into like, hey, how do you do power and sample size for type 2s? In types 1 and 3, it's relatively straightforward. It's how you do it anyway for regular clinical trials or cluster randomized trials. It's kind of the same. But for these type 2s, it's weird stuff. And so these mathos came in and figured it out. And it's there for you, but don't ask me for any help on that. So this is a new paper on sort of more practical applications of it. It's only like 2 months old or something. And hopefully, not by the time I get home on Wednesday, but hopefully by the end of this year, we have a brand new paper which goes into much more detail on sort of hybrid 1 approaches and varying ways to dig into the hybrid 1 stuff. So that's coming soon. I'm done. How did I do? Like,
you're a little over.
Okay. Excellent. Thank you so much, Geoff. We can open the floor. We have about 10 minutes for questions.